The today's talk is on RBC parameters on the modern cell counters. Okay, so I'll be taking this talk under the following layout: basic principles in the RBC parameters. As we all know that automated red cell counters are becoming very sophisticated and they generate more reportable parameters. And a lot of new parameters have come up in a lot of machines. But today we're going to focus only on red cell parameters. So as we all know that the modern cell counters are basically based on various principles. It can be either a VCS, that is volume conductivity and scatter principle, which is in Beckman Coulter's, or peroxidase staining in Siemens, and fluorescence flow cytometry in Sysmex. So whenever whenever the light particle hits the cell, we all know that we get a forward scatter, which gives information about size. We get a side scatter, which gives information about intracellular information like granules. And using a dichroic mirror, we also get a side fluorescence light, SFL, which gives us the information about the amount and the type of nucleic acid and the cell organelles. So whenever we are talking about the different channels, different parameters, as we all know that we get the basic panel. If you look at the fluorescence versus side scatter, we get eosinophils, neutrophils and basophils, monocytes and lymphocytes. So these channels, if you talk about Sysmex Coulters, these parameters are given names as WDF, that is white cell differentials, in which we can have eosinophils, neutrophils and basophils and lymphocyte, monocytes, which are separated. And this is the region where nucleated RBCs come. Just a second. Okay, so this is the region where the nucleated RBCs are coming. So this channel is called WDF channel, whereas we also have WINR channel, in which the WBCs are basically separated from nucleated RBCs and basophils. And also we have white cell progenitor channels, which we already know can give us progenitor gates. So if we look at the WNR scattergram, we have side fluorescence light on the x-axis and the y-axis has forward scatter. And here we have a predominant chunk of WBCs, and here a chunk comes of nucleated RBCs, and on top we have basophils. So can anybody answer this question? What do you think is this? This is WNR channel, and again forward scatter and SFL. And who is going to tell me what are we seeing here? Anybody? Can anybody tell me this? What is this channel? What is this pink population here? These are nucleated RBCs. As we have seen, we have WBC here, and here we will get nucleated red cells. So if you look at this case has a lot of nucleated red blood cells. So just looking at WNR channel itself, you will get information that this person has circulating nucleated RBCs in the peripheral blood. So nucleated RBC count, is it important? Why do we need it? Because see, in neonate, when we have WBCs, if there are high NRBCs, we need to correct the WBC count, because these nucleated RBCs can be counted with WBCs. So they need to be corrected. Whereas when we're talking about adults, even a very small amount of nucleated RBCs, if they're coming in the peripheral blood, it is significant. So let's look at this case here. So this is a XN 1000 plot, and here this is how the report comes to us. And if you look at this WNR channel, everyone, here there is a big chunk coming here. This chunk, if we look at this, so this chunk is your WBC and basophils, and here nothing is there. That means there are no nucleated RBCs. So this person has no nucleated RBCs. So that means this is a correct report for whenever we see in this channel NRBC, this is where the report is going to come for NRBCs. So whenever we are talking about XN analyzers, NRBC comes in nearly every report, and it gives a linearity of about 600 NRBC per 100 WBC, and auto correction is done automatically. So here you needn't auto correct for it. Whereas if we're looking at Beckman Coulters, here the nucleated RBCs are coming in this region. Okay, so this is the region where the nucleated RBCs come in the Beckman Coulters. Okay, right. Whereas in XN parameters, Sysmex, we have seen this is the region where your nucleated RBCs are going to come. Okay, so nucleated RBC, if you look at about Horiba also allows quantification of NRBCs, and here it is called ERB, and it can be separated from leukocyte by volume and from platelets by their fluorescence difference using a stain thiazole orange. And this WBC is then corrected for the presence of ERB. So if you look at this, this is Simon's. This machine is Advia Simon's machine. If you look at this, it comes in peroxidase negative channel. So this is the region where your nucleated RBCs come on Siemens. So that's again, here also the WBC and differential are corrected for the presence of NRBCs. Okay, so let's look at this case. Can you identify this case? What does this case mean? Anybody? Can you analyze this case, please? Can you tell your answer? You can write your answer in the chat boxes. So what is this? This is a 10-year-old female and she had anemia. And when we look at the Coulter, we found, so you can see a big chunk coming here. Okay, so this is WBC. I've shown you the earlier graph also, but here a big chunk is coming here. That means there are nucleated RBCs in this report. Again, if you look at this, look at the nucleated RBC. The nucleated RBCs are present in this case. So now what will you do? So this is a 10-year-old female. She is having nucleated RBCs. So what are you going to do now? So you know nucleated RBCs are coming. Again, the indices, if you see MCV, MCHC, this is a microcytic hypochromic indices. And along with nucleated RBC, you should actually get a reticulocyte count also done. But here we don't have a reticulocyte count. Okay, and here this RBC parameter on this also shows you it's a microcytic hypochromic picture. A nucleated RBC is coming on the WNR. We will immediately order HPLC. So that's what we did. So this we sent for HPLC. As soon as the HPLC comes, you see what you see? You see a big peak in the A2 window. So this comes at the retention time of 3.73, a 64%. And all of you know hemoglobin E usually elutes in A2 window. Apart from that, you can see hemoglobin F is also very high, 32.4 with these kind of indices. Okay, with this kind of indices and your nucleated RBC circulating and your F also high and E A2 also very high. So then you will suspect E beta. So this patient, what will you do next? You will do parental screening, and in this patient also we did parental screening. One of the parent came out to be E and the other parent came out to be beta thal. So this was a E beta thal patient, and the Coulter gave us a trigger to identify and come to the final diagnosis. Now, once I told you in this case that reticulocyte count was not done, that means we go to the next RBC parameter, which is very, very important. This is called reticulocyte channel. So all of you know that reticulocytes, you know, most of the automated reticulocyte count methods, basically they are based on the principle of ability of the stains to bind to the RNA in the reticulocyte. Okay, and it is definitely better than manual. Why? Because manually we can count maximum 1,000 cells, but machine is counting approximately 32,000 cells. So it's better than manual. And obviously we can easily separate reticulocyte from the non-reticulocyte because the reticulocytes are separated from the mature RBCs. So let's look at this red channel. So whenever we're looking at this, this is a Sysmex X-class analyzer. And in this, basically, RBCs come as a separate chunk here, and apart from that all this here comes as a reticulocyte. And on the basis of the fluorescence, because we know what is the plot here, on the x-axis we have SFL, that is fluorescence, and on the y-axis we have FSC. So on the basis of SFL and FSC, we have on the basis of the fluorescence, reticulocytes can be divided into three parameters. One is LFR, low fluorescence, MFR, mid fluorescence, HFR, high fluorescence. So whenever we see this, majority of the normal reticulocyte belongs to LFR region. That is about approximately 86.5 to 98.5% of the cells reticulocytes are LFR, whereas only 1.5 to 11% are in mid region and only about 0 to 1.5 are in high region. So whenever we combine these two, that is mid and high, this is called as immature reticulocyte fraction. So now what is the significance of immature reticulocyte fraction? This is a reportable parameter which is given on the Sysmex analyzer. So whenever you do a reticulocyte count, you are able to see these two parameters here. You can see reticulocyte count and IRF. That is Now, IRF is actually a combination of mid and high fluorescence, and these two parameters will come together. So this parameter, so whenever we talk about this immature reticulocyte fraction, this is actually a sum of mid and high fluorescence ratio to the lower fluorescent ratio, and this is also called as reticulocyte maturation index. We should know the normal value of this. So this IRF, basically in females it can range from 1.1 to 15%, and in males approximately 1.5 to 13%. So if you look at this, this is your retic channel, and this is again FSC and side fluorescence. And if you focus on this big chunk here is nothing but your RBCs. And can you see the majority of the cells fall in the low fluorescence region? There are few cells which are falling here in the mid and high fluorescence region, which can be reported as IRF. And you can see IRF in this person is 8.8, which is in the normal range. So there's no problem in such. This is your normal reticulocyte channel. Okay, so what is the utility of IRF? Why and where to use it? See, this is basically used to assess the response to iron or vitamin B12 folate supplementation, and especially to monitor patients on erythropoietin. It is also an alternative for absolute neutrophil count for monitoring recovery after bone marrow transplants. So even whenever we have bone marrow transplants, it starts to rise 5 to 7 days post bone marrow transplant, and it reaches more than 10% at approximately 14th days, and it is not affected by infections, and it's a very useful indicator of impaired bone marrow function following chemotherapy-induced bone marrow aplasias. So if you look at this algorithm, which was reported in the Indian Pediatrics 2017 journal, in this, they said that if the reticulocyte count is high and IRF is also high, it basically indicates acute hemolysis or blood loss. If your reticulocyte count is very high, IRF is also high, but retic is more high, okay, then you should think of hereditary spherocytosis. But if your reticulocyte count is normal and your IRF is still coming high, then you should think of megaloblastic anemia. Again, reticulocyte count is low, but IRF is normal, then you should start thinking of IDA and ACDs. And if both are low, that is retic is also low and IRF is also low, then you should think of aplastic anemia. So this is a very beautiful algorithm which helps you to pinpoint the diagnosis at the Coulter level itself. Again, if we look at the equipments, okay, how do they differ in relation to the reporting of IRF? So whenever we talk about Sysmex Coulters, they have a stain called oxazine 750, which helps in picking up these reticulocytes. Now, oxazine 750 is a nucleic acid dye. It binds to both DNA and RNA. Mind you, what is the point here is that reticulocytes have more RNA. Therefore, they can be differentiated from WBCs very well because WBCs have more DNA. So, on the basis of the difference in the fluorescence itself, reticulocytes are separated from the WBCs. So, this is on basis of oxazine 750 dye. Whereas when we talk about Beckman Coulters, they have a non-fluorescent stain for staining reticulocyte. This is methylene blue, and the methodology that they use is VCS, that is volume, conductivity, and scatter. Now, if we look at the other reticulocyte or advanced reticulocyte parameters, which we should know, so one of them is MRV. Okay, so MRV is nothing but it is actually a reticulocyte equivalent of MCV. Okay, so mean corpuscular volume, just like that we see the volume of RBC, same way if we are seeing the volume of the reticulocyte, this is called as MRV. And what is the utility? See, whenever we're talking about MCV, that is the volume of RBC, basically it varies over a period of 120 days. Whereas when we talk about reticulocyte, its volume is going to alter in 2 days itself. So it's a very good parameter to see the acute changes. So it reduces and increases very quickly in response to iron deficiency or B12 and folic acid deficiency, or even during erythropoietic recovery in bone marrow transplantation, even EBO abuse in sports. It's a very good parameter. And the drawback is it's still not standardized. Although its mean has been reported to as 110.8, it has limited availability in few Coulters only. Let's come to the next parameter, that is the equivalent of MCH. So same way, mean corpuscular hemoglobin is there. So what is the reticulocyte equivalent of mean corpuscular hemoglobin? This is basically your reticulocyte hemoglobin, and it basically detects your, again, because it's detecting your hemoglobin content of the reticulocyte. It is more sensitive than conventional iron studies in diagnosing iron deficiency. So it's a better parameter to detect iron deficiency, and its reference range is 28 to 30 picogram. So So when we talk about the another parameter which is now available in XN parameter, XN coolters, this is red heat, which is a very diagnostical reportable parameter. It is a reportable parameter, and it's the I'm sure whoever is using Sysmex coolter will be using this parameter. This basically detects the hemoglobin content in the reticulocyte, and it is a it's a very sensitive indicator for iron availability for erythropoiesis. So red He and red percentage are basically, they give a very good information to clinicians regarding quality and quantity of erythropoiesis. So if you look at the European best practice guidelines for management of anemia of chronic renal failure, they recommend that functional iron available for erythropoiesis can be assessed by any one parameter, which you can use: percentage of hyperchromic RBCs, which we'll be seeing later, or transferrin saturation, or red heat. If you look at the National Kidney Foundation guidelines, this means they say that initial assessment of anemia should include a CBC, absolute reticulocyte count, serum ferritin to assess iron stores, transferrin saturation, or red He, or you can use CHR to assess adequacy of iron for erythropoiesis. So if we use red He, can we make an algorithm? Yes. So this algorithm has been given in many publications. So if you use red He and you use a person has a high or normal ferritin value, but still the red He value is low, this means a person is having a functional iron deficiency. But if the ferritin is also low and red He is also low, that is actually a case of classical iron deficiency. So red He is actually used for monitoring erythropoietin and following erythropoietin and also IV iron therapy. And if the value increases, it indicates the therapy is having a positive effect. So if you look at the guidelines, okay, so they say that if a patient, normally a red He value of below 27.2 is able to predict iron deficiency with a sensitivity of 93.3% and specificity of 83%. But in cases of CKD, a red He value less than 25 picograms suggests an iron deficiency. So if we use a flow chart again, which is given by Indian Pediatrics 2017, this is iron restrictive erythropoietic markers. So what are the new iron restrictive erythropoiesis markers that have been suggested are red He, percentage of hypochromic red cells, which we're going to talk later. So these can be used. Okay, so and they have given an algorithm that what is the cutoff percentages which we should use in a patient of CKD with anemia. So if we look at the availability and comparison between different coolters, Siemens basically use CHR, which is nothing but a mean reticulocyte hemoglobin concentration, and the Sysmex, that is red He. If you look at the delta He, so what do you understand by delta He? Delta He is nothing but, so this is actually considered as a difference. So all of you know, this is the plot which we studied: forward scatter and side fluorescence, and this big chunk here is the RBC, and here comes your reticulocytes, that is lower fluorescent intensity. So if you are using RBC hemoglobin and your reticulocyte hemoglobin and you subtract both of them, this gives you a parameter called as delta He, and delta He, the value is 1.7 to 4.4 picogram, and this gives you information about the hemoglobin. So this basically gives you a very good information, like how much is the hemoglobinization in the reticulocyte. See, what is the utility is that whenever a person has inflammation, there are a lot of cytokines which are released, like interleukin 6. Okay, so just a second, is there any problem in the video?
No, ma'am.
No. Okay, somebody raised hand, I think. Okay, so in cases of inflammation like cytokine 6 or when interleukin 6 is released, lot of acute phase reactants are released, iron gets trapped inside the cell and it is not available for erythropoiesis. So what is going to happen is that the newly formed reticulocytes are going to get hypochromic, but original RBCs have a lifespan of 120 days, so they'll be normal, whereas the new reticulocytes that are going to come out will be hypochromic. So this negative value basically results from lower hemoglobinization of reticulocytes. So this parameter also can be used in algorithms. Okay, so if you're looking about delta he, what did we study till now? First, that this basically is a very fast monitoring for infectious process, and it gives you a very sensitive and early marker for intracellular iron deficiency, isn't it? So if you're looking at this, so whenever your delta he marker goes negative, so this was a publication which was done in Clinical Kidney Journal 2014. So whenever there is an inflammation, this could be easily assessed by delta he, because it gives you a very good marker for early onset intracellular iron deficiency. So coming to the next parameters, which was again suggested by the kidney guidelines, that was percentage of hypochromic cells. So this basically is that how much, this is the percentage of hypochromic cells is actually the concentration of hemoglobin in individual cell rather than mean. So whenever we are taking mean of all the cells together, that was given by the red heat parameters. But when we talk about individual cell, that how much is the concentration of hemoglobin in an individual cell, it is a percentage hypochromic cell. So if you're talking about the normal percentage of hypochromic cell, they should be actually less than 5% in a normal individual. Whenever the percentage of hypochromic cell becomes more than 10%, this is basically a very useful parameter for defining your iron deficiency. It can be absolute iron deficiency or functional iron deficiency, but it is an iron deficiency. So the cutoff has been revised for patients with iron deficiency in hemodialysis. So in patients of hemodialysis, 2.7% is considered as a cutoff. So again, now if we talk about it, suppose we are talking about thal major and iron deficiency anemia. So how does it matter? All of the, or anemia of chronic disease, all are going to have hypochromic cells. So is there a difference in all these three? So highest number of percentage hypochromic cells are seen in thal major, followed by iron deficiency anemia, followed by anemia of chronic disease, and it has also been incorporated in the guidelines for monitoring recombinant human erythropoietin therapy. The disadvantages that it is a poorer parameter than reticulocyte hemoglobin in picking up functional iron deficiency or monitoring the anemia treatment, because it will only identify the concentration of hemoglobin in an individual cell, and this parameter is only available in Siemens and Sysmex. So we come to the next parameter, that is LHD, which we also saw in the guidelines, low hemoglobin density. This is the parameter which is available in the Beckman-Coulters, and it is derived from the sigmoid transformation of MCHC, and it is given by the formula which I've mentioned here, and it indicates the iron availability and hemoglobinization of mature red cells. Now, problem is that there is no internal quality control which is available, and of course, the percentage normal is approximately given as the range of 0.9 to 4.1. Whereas if you look at the ACD, the ranges that have been defined is 4.5 to 68. And if it's a combination of ACD and iron deficiency anemia, definitely the low hemoglobin density is going to increase. So if, let's say, if we are talking about ACD, LHD is 14. But in cases of the combined ACD iron deficiency, this is going to be 24.1. Whereas if the patient has ACD and iron is okay in that patient, the range is going to be only 10 to 12%. So that is how we can pick up a combined ACD iron deficiency with the help of this parameter called as low hemoglobin density, which is present in the Beckman-Coulters. Now coming to the new parameter, that is hypo-He and hyper-He. Again, this parameter is available in Sysmex XN. So if you look at this, so basically this is, again, it's a proprietary algorithm, and how it is calculated as that, this is, all of you know, this is the RBC chunk here. Okay, so the percentage of RBCs which have a cellular hemoglobin less than 17 picogram comes in this region, hypo-He, and whereas hyper-He is percentage of RBCs which basically comes in more than 49 picogram. So I'll give you an example. So this is an RBC, and let's say this percentage is your hypo-He. So here you can see here that the number of hypochromic RBCs, the lot of cells are coming in this lower window here. So hypo-He here is more than 60. Whereas look at this RBC chunk is actually coming at the normal place here, RBC here, and this here, the space here is actually less. So there are less percentage of cells which are falling in this region. So here the hypo-He value is less than 1%. So hypo-He is basically percentage of RBCs which have a hemoglobin content less than 17 picograms. And it's, again, you can see here, it can be easily picked up. It is a proprietary algorithm, and you can identify it here like this. So what is the difference if we are talking about hypo-E and micro-R? What is the difference in this? So whenever we are talking about micro-R, that is the I think I'm going to tell you micro-R afterwards. So here, what are micro-R first? So whenever you look at the RBC histogram, if you look at this, so the percentage of the cells which are falling in this region are considered as micro-R. So percentage of microcytic RBCs which have a volume of less than 60 femtoliters. So what is the cutoff that is defined as 60 femtoliters? So percentage of cells which fall less than 60 are considered as micro-R, whereas percentage of cells which come here that is more than 120 femtoliter comes as macro-R. So we have micro-R and we have macro-R. So they are expressed in percentage of all the RBCs. Okay, so they are again two diagnostically reportable parameters which are given in the CBC. So if you're talking about this, so now we have hypo-E that gives you a degree of hypochromia, and micro-R which gives you a degree of microcytic hypochromic cells. Okay, so what is the difference is that micro-R is increased in beta thalassemia patients more than the iron deficiency anemia, whereas when we talk about hypo-E, the values are not different in beta thalassemia versus IDA. So remember this point. So that is what we study. If you look at the Windrobes, okay, that is what we see. So micro-Rs are basically microcytic cells. Micro-Rs are more increased in thalassemia subjects as compared to iron deficiency anemia, whereas hypo-E values are not different. So both are hypochromic. Again, they have said that in subjects with beta thalassemia, percentage of hypochromic E results are below the reference range because of ineffective erythropoiesis, resulting in reduced production of intact hemoglobin. And they're also same way in iron deficiency anemia, there is iron deficient erythropoiesis. So there also we have a lot of percentage of hypo-E cells, but the difference is not significant, whereas micro-R are more in cases of beta thal patients. So if you look at these parameters, both these parameters, looking at the parameters itself, it will give you an idea that are we dealing with IDA or thalassemia without even seeing the slide. So nucleated RBCs you can see micro-R, you can see hypo-R. So they'll give you very beautiful parameters of what is the case or what your slides are going to look like. So again, if you look at the European best practice guidelines, then these recommend the use of hypo-E as well as micro-R, and they are basically increased in iron deficient erythropoiesis, and they are these parameters are good and nicely devised to differentiate between IDA and beta thalassemia. So again, there is a suggestion that if a person has normal MCV along with increased micro-R or macro-R is usually observed in myelodysplastic syndromes. So let's look at the condition in which if we look at the algorithm and what are the cutoffs that have been defined to differentiate IDA from beta thalassemia. So this is a paper which is published in American Journal of Clinical Pathology, and in this the guidelines was suggested that, and they had given a devised formulas that if, and they've given the cutoffs that if this cutoff is followed, this is a pure case of IDA. If this cutoff is followed, it's a pure case of beta thalassemia. So these algorithms can be followed with every condition. Like first you see the MCV. Okay, if your MCV is falling in this range, then what formula you should use? Again, the major cutoff that they have used is MCV less than 85, and the second is micro-R should be more than 3%. And after that, they have devised various algorithms to differentiate these categories. Coming to the next new RBC parameters which have come up, this is again mean sphered cell volume. So all of you now know MRV, that is mean reticulocyte volume, that is the volume of the reticulocytes, isn't it? So now whenever we talking about MRV, that is mean reticulocyte volume, in cases of spherocytes, if a person has spherocyte, we take the volume of reticulocytes also and spherocytic cells also. So this volume together of RBCs and spherocytes is called as MSCV, that is mean sphered cell volume. So here mean sphered cell volume is the volume of RBCs as well as reticulocytes, whereas MRV is the volume of your reticulocytes. So they calculated a value called as delta. So what was delta? Delta was MCV minus MCHC. So MCCV, that is mean sphered cell volume. Obviously, they said that if this value is more than 9.6, so this gives you a very good suggestion that a person is having spherocytosis. Also, they gave that usually in cases of spherocytosis, the MRV, obviously the mean reticulocyte volume will be decreased, and MCV, definitely mean sphered cell volume will be less than MCV. So they gave a formula here. If you subtract mean corpuscular volume minus mean sphered cell volume, and the difference comes to be more than 10. And if you subtract the mean reticulocyte volume minus mean sphered cell volume, and the cutoff comes to be less than 25, basically this can be used as the threshold for hereditary spherocytosis. So this update was basically published in 2021 in Journal of Clinical Lab, and they gave this algorithm. So they gave the diagnostic protocol. So they said that whenever you're suspecting a patient of spherocytosis, look at these parameters. So parameters that were suggested were reticulocyte count is increased, your mean reticulocyte volume is decreased, your value of mean sphered cell volume is less than mean corpuscular volume, of course your spherocytes are increased, and your unconjugated bilirubin is increased. Again, this is a paper which is published in Hematology 2018, and it basically suggests that whenever you're suspecting spherocytosis due to any cause, this is spherocytosis or autoimmune hemolytic anemia, you just subtract the mean sphered cell volume from MCV. If it comes out to be more than 10, it indicates your spherocytes. And you can
Ma'am, your voice is breaking, ma'am.
mean sphered cell volume from mean than 25, then you should think of likely HS. Again, a very beautiful. Is it okay now?
Yes, ma'am.
Is it okay now?
Now it is. Ma'am, it's breaking. I think it's breaking.
Okay. Is it okay now?
Now it is okay, ma'am.
Okay, so now like this is the RBC parameter, this is the platelet, and in between if something comes here, okay, so if you know what all can come here, just now you've seen either there will be hypochromic red cells which can come here, or RBC fragments also will come in this range. So this parameter which detects the fragments here isolatedly, this is called FRC. This is called fragmented red cell. FRC, that is fragmented red cell. This is a research parameter. So what does this say? So again, this was a guideline which was published now in 2022, and they say that if schistocytes are prominently seen on the RBC, then you count the 1000 RBC, and the cutoff that they defined was that if the percentage of schistocytes are more than 1% in adults, and in premature baby if it is more than 5%, then you should suspect a thrombotic microangiopathy. The another parameter that they suggested was FRC. So what is this fragmented red cell parameter? It just gives you the percentage of fragmented red cells. So the 2021 update that came up was that FRC results and flags are provided by automated counter, and they are very helpful screening test for assessing schistocytes. If there is absent of FRC, it's a valuable parameter to exclude schistocytes on the peripheral blood, except when the MCV is elevated, and then you should check it with morphology. And then it is still a research parameter. And if FRC is coming positive, you should review on morphology and count the percentage of schistocyte. The cutoff that has been revised is now more than 1%. So if you look at this parameter, fragmented red cell parameter, is it given in the other instruments or not? Let's see. So when we look at the ADVIA instruments, so no, this is the plot that comes here. This is a platelet scattergram. And the first here comes the RBC ghost. This is second area is platelets, and third area is your RBC fragments. As you look at the case 1, this is normal, but look at the case 3 here. Here, a lot of cells are there in this area. This is RBC fragment area. So how does it indicate us? They pick up particles with volume less than 30 femtoliter and with refractive index less than 1.4 to differentiate them from the large platelets. Whereas when we look at the Sysmex, we have already seen that they use reticulocyte channel to quantitate schistocytes, and they pick up the smallest event in the red cell area with low RNA content, and that is how they pick up these fragmented red cells. So if we make a summary of all the new RBC parameters that we've seen, and if you try to think over that, can you remember these? So I hope everybody remembers hypochromic RBCs, reticulocyte hemoglobin concentration, hypochromic RBCs have been reported as hypo percentage in Siemens, CHR in Siemens. Percentage of hypochromic RBCs is reported as percentage AHPO in Abbott, MCHR in Abbott. In Sysmex, they are reported as hypo-He and red-He. Low hemoglobin density parameter is given by Beckman-Coulter. So depending upon which Coulter you are using, the parameters are there, but they have different names. So can you identify this? Who is going to tell me what is this? Anybody who can try this now? Anybody? Any guesses? You can write in the chat boxes. What is this? Guess anything? Very good, Shakir, you're right. This is reticulocyte which is given, but can you see the RBC and the reticulocyte chunk are just juxtaposing with each other? They are just connected to each other. It looks like they're stuck to each other, isn't it? So whenever you look at this overlapping of RBC cluster with the reticulocyte cluster, this basically makes you think of some abnormality on the smear, and usually there is some interfering substances. It can be a Howell Jolly body, or it can be a basophilic stippling, or it can be a malarial parasite, or it can be nucleated RBCs or fragmented red cells, but fragmented red cells will come usually here in this region. So therefore, you should always see the smear in these cases, because there might be Howell Jolly body or stipplings or malaria parasite which you're missing out. Let's look at another case. Who's going to tell me what is this? Quick guess, what is this? I think my time is also over. So quickly, can you tell me what is this? Very good, iPhone. Perfect. So these are fragmented red cells. Good, Dr. Shakir. Good. Very good, Dr. Nazia. Perfect. So this is actually a fragmented red cells, which we have already seen. Okay. Right. So fragmented red cells. Perfect. Look at this smear and you'll be able to find these fragmented cells. Okay, just an update here. So this is an XN30 and they have just come up with a new parameter for detecting malarial parasite. And this parameter is called MIRBC, that is malarial infected RBC. And they use a dye called lyseril, which basically detects the fluorescence by the malarial parasites. So this is a new parameter which is coming up, and let's see how it works. So to summarize, so new parameters look very attractive and they should be standardized between different manufacturer instruments because they have different names in different instruments. Many of them are research parameters, and there's some of the parameters we require additional costs which we have to be done for the additional reagent. Any flag always mandates a necessary microscopic examination. Both internal quality control and external quality control are needed for better reporting. And when these parameters are utilized, they provide a very good evidence for providing a better diagnosis. Thank you so much.
I'm Dr. Richa Gupta, and I'm Professor of Pathology working in University College of Medical Sciences, Delhi. And my talk today is about flow cytometry, the use of flow cytometry in hemolytic anemias. So flow cytometer is something which we all know about. It has become very popular since the last 2-3 decades, and almost all good institutions now have a flow cytometer. But if we talk about uses of flow cytometry, so most of you would tell me, if I ask most of you, you would tell me about immunophenotyping of leukemias, lymphomas, of other malignant disorders. And in India per se, the use of flow cytometry for benign disorders has not gained so much of vogue. So that is why this topic is something which is really close to my heart. I would tell you how flow cytometer can also be used for evaluating so many benign hematological disorders as well as immunological disorders. So today I'll be limiting my talk to about the use of flow cytometry in hemolytic anemias. Next, please. So in this presentation, I would take you through the principle of flow cytometry and how it can be applied for the diagnosis of some hematological disorders, especially paroxysmal nocturnal hemoglobinuria, hereditary spherocytosis, autoimmune hemolytic anemias, and for the evaluation of fetal-maternal hemorrhage. Next, please. So if we talk about the principle of flow cytometry, we all know that in flow cytometer, there are three things: the fluidics, the optics, and the electronic system. So talking about the fluidics, we know that the cells in flow cytometry, they are suspended in a form of a suspension. The sample is always liquid, and then it is injected into a detection tube where the cells pass through a detection tube in a single file. And this is known as hydrodynamic focusing. And this is achieved by the help of a sheath fluid, which runs around the cells at a particular pressure and velocity. So this is called hydrodynamic focusing. The cells go through this detection tube one after the other. And when they go through this tube, the laser strikes the cell. Laser is a monochromatic light which hits the cell. And once the laser hits the cell, this light is scattered in all directions, right? So, and this scattered light is then it passes through the filters. We take the desired wavelength or the desired light, and then it is passed through detectors. This constitutes the filters and the detectors. They constitute the optical system of the flow cytometer. And finally, the signals are amplified. They are converted into digital signals and they are sent to the computer where you can actually read the signals. So that is the electronic part of flow cytometer. Next, please. Next. Next, please. Yeah. So here again, I'm just showing you that when a laser beam strikes the cell, obviously the cell is going to scatter light in all 360 degrees. Okay. So, but what we are interested or we are looking at is two angle scatters. One is the forward angle scatter, which is just 5 to 10 degrees from the direction of light. And the forward angle scatter tells us about the size of the cell. The greater the size of the cell, the greater will be the forward angle scatter. And the other thing which we capture or we look at is the 90-degree scatter, which is the side scatter, or which tells us about the granularity of the cell. Apart from that, what we also do by flow cytometry is immunophenotype, right? And how is it done? These cells are pre-treated by secondary antibodies, which are labeled to certain fluorochromes. And every cell will have a certain antigenic signature, right? So every cell, depending on what antigen it expresses on the cell, you can identify the type of the cell. And also you can know whether that antigen is expressed appropriately on the cell or the density is reduced or increased, okay? So when a fluorochrome tagged cell passes through the detector, the light is going to excite the fluorochrome, which will emit light of a certain fluorescence, which is again taken up by detectors, and the fluorescence is red. So we can know which antigen is being expressed, overexpressed, underexpressed on a cell, right? Next, please. So this diagram is showing you the same thing, that the laser beam strikes the cell. It scatters the light as well as it emits a light of certain fluorescence. And this is detected and amplified by a photomultiplier tube, goes to the computer, which generates signals mainly in the form of graphs. Okay, so this is a common graph which we use. The two most common graphs which are used here is the histogram or the frequency distribution graph, and the other one is the dot plot. The dot plot is a 2-parameter histogram. One of the parameter is represented on the x-axis and the other parameter on the y-axis. Next, please. So talking about histograms, these are the simple ways we read a histogram. Histogram is a frequency distribution where there is a logarithmic scale on the x-axis, and you take a certain fluorochrome expression on this axis, and on the y-axis is the number of counts. So here you can see that most of the cells, they are expressing a very low amount of the fluorochrome, or we can say that it is negative for a particular antigen. While here, these cells are expressing a lot of events. Most of the events, they lie in the high fluorescence intensity. So they are positive for a given fluorochrome or for a given antigen to which the fluorochrome had been tagged. And if we talk about 2-parameter histograms, we have a dot plot. One of the fluorochrome is represented here. The other fluorochrome which is tagged to another antibody, is represented here. So we can read the cell populations, whether they are expressing one or both of these fluorochromes or none of these fluorochromes. For example, this green population, it expresses the fluorochrome of the x-axis, but not of the y-axis. The red population here is expressing the fluorochrome, which is represented on the y-axis. This is a dual positive population, and this is a double negative population. Next, please. So advantages of flow cytometry are it is very quick, it is multi-parametric, we can study multiple parameters simultaneously. And because we, in a very small time, we analyze a large amount of cells, we can also see rare populations. The main disadvantage is that you cannot comment on architecture, because whatever be the architecture, you have to suspend the cells in the form of a liquid or a suspension medium. And obviously the instrument is relatively expensive. Next, please. So with this basic knowledge of flow cytometry, we now come to paroxysmal nocturnal hemoglobinuria. Yeah, next, please. So before I tell you what is PNH, I am showing you a simple diagram. This is the lipid bilayer of every cell. We know that every cell membrane, living cells, they have a lipid bilayer. And the proteins are attached to the lipid bilayer in different ways. So, for example, some of the proteins are transmembrane proteins. They run all through the membrane. This can be a single pass transmembrane protein, or they can be multiple pass transmembrane proteins. Some proteins, they form a barrel-shaped structure. They become a channel to allow access through of certain ions through the channel. Then they can be proteins which may be incompletely passing through the cell membrane, and they can be peripheral membrane proteins. Another type of protein which today we are interested is the GPI anchored proteins. They are not directly attached to the lipid bilayer, but to get attached to the lipid bilayer, they require an anchor. We look at another diagram for this. Next, please. So here you can see I am just showing you a detailed structure of the GPI anchor. This is the protein which needs to be attached to the lipid bilayer. Instead of attaching directly to the lipid bilayer, it needs an anchor here, which is known as a phosphatidylinositol glycosed anchor. So this is the structure of the anchor, and the protein is attached to the anchor in the carboxy terminus, and in turn, the anchor is attached to the lipid bilayer. Next. So what happens exactly in PNH is that this GPI anchor is not synthesized. And why it is not synthesized? Because the gene which makes the GPI anchor, that is the PIG-A gene, phosphatidylinositol glycan A gene, this is mutated. Now, important here, it is to remember that it is the PIG-A gene mutation occurs at the level of the pluripotent stem cell. Okay, so all lineages, all hematopoietic lineages, be it the lymphocytes, the monocytes, the neutrophils, or the other granulocytes, apart from red cells and even platelets, they all will show you deficiency in the GPI anchored proteins. PNH has been traditionally classified as primary or secondary. Primary when it is not associated with any other disease, and secondary when it occurs in the background of aplastic anemia and MDS. So there's a huge list of GPI anchored proteins. For example, the important ones which give rise to a lot of pathogenesis in PNH are CD55 and 59. These are two GPI anchored proteins present on red cells, which prevent complement-mediated hemolysis of the red cells. Then you very well know what is leukocyte alkaline phosphatase. We use it in the NAP score. So the lab protein is also missing when there is a GPI anchor deficiency, when there is PNH, and then there is a long list of other proteins which are expressed on different set of cells. Next, please. So this is in brief the pathogenesis of PNH. It is said that PNH or the mutations of this PIG-A gene, they arise in the hematopoietic stem cells in the background of some kind of marrow damage. And that is why PNH is seen in association with aplastic anemia and MDS. So there is some kind of marrow damage which gives survival advantage to those cells which carry a PIG-A gene mutation, and they start proliferating in the hematopoietic system or the bone marrow. So then, because the PIG-A gene is mutated, all these cells will have loss of several GPI anchored membrane proteins. For example, the red cells, they do not have CD55 and 59, which makes them prone to complement-mediated hemolysis. So these patients will present with intravascular hemolysis, hemoglobinuria, and consequently anemia. Also, the complement-driven, there is activation of platelets because the GPI anchored proteins are absent. So the complement-driven activation of platelets take place, which leads to a hypercoagulable state. And thrombotic events are very common in these patients, especially they can be unusual site thrombosis like mesenteric vein, the Budd-Chiari syndrome, pulmonary arterial hypertension. All these features can be noticed in patients of PNH. Also, because the platelets are being consumed here in this hypercoagulable state, there is thrombocytopenia and increased risk of bleeding. The same GPI anchored proteins, they are also absent from the neutrophils, and as a result, the neutrophil survival is reduced, which makes the patient pancytopenic and also prone to new infections. So these are some of the symptoms in which by which these patients can present anemia, mainly intravascular hemolysis, thrombosis, and pancytopenia. Next, please. So one thing which you need to remember here is that PNH is a phenotypically, it's a disease in which you observe phenotypic mosaicism, because the kind of mutation, the mutation which occurs in the pluripotent hematopoietic stem cells, that is the PIGA gene mutation, it may not be same in all the cells of the hematopoietic lineage. Okay. So depending on the type of mutations, we can get 3 types of clones of PNH in the same patient. PNH1 clones are those cells which do not have any mutations in the PIGA gene and they are not deficient in the GPI anchored proteins. While PNH3 clones are those cells which completely lack the GPI anchored proteins, which arise from mutations. Such mutations which completely lack the GPI anchored proteins and therefore are most affected. And in between PNH1 and PNH3, we have the PNH2 clones which show a partial deficiency in the GPI anchored proteins. The same patient can show you all 3 clones or one of the 2 clones. Next. So if we talk about the diagnosis about paroxysmal nocturnal hemoglobinuria, traditionally paroxysmal nocturnal hemoglobinuria was diagnosed with the help of HAMS test and sucrose lysis test. Now these tests are good if they are done in a very proper way. So they need a lot of stringent quality control, and generally you would, if they're not done in a very proper way, they're subjective and the sensitivity is also not very high. So that is why HAMS and sucrose lysis tests were replaced by newer tests. One of them is the gel card test or the cefacril gel card. You all must have seen a gel card in the blood bank or maybe in the hemolytic lab also. Now these gel cards, what is here in the gel card is there is a gel, there are 6 wells generally in one card, and there's a gel inside the card. Now what this gel is doing here is that it is generally helping the red cells to agglutinate. Okay, they are increasing the antigen antibody interactions and helping the red cells to agglutinate. Now the gel here is already incorporated with the help along with a certain antibody, and the name of the antibody is just written below the well. For example, in this gel you already have CD55 or CD59 incorporated here. So what happens here, you add a red cell pellet, and if you see that the pellet stops at the top, that means an antigen antibody reaction took place. The antigen was there on the cell and therefore agglutination happened, the red cells agglutinated, and that is why they were not able to pass to the bottom of the cell. So whenever the cells are able to pass to the bottom, that means the antigen antibody reaction has not taken place. So there are 2 patients, 1 and 2. Can somebody write me in the chat box who is a patient who has PNH here? Who is the patient who actually has PNH? No, I just want to go to the back slide. Anyone can tell me in amongst patient 1 and 2, which patient has PNH and which is a normal control? Yeah, so somebody is writing number 1, Pallavi. Pooja Sharma writes patient number 2. So actually it is patient number 2 who lacks. Jay is writing patient number 1. So abhi 50-50 chal raha hai. Half of the people think that PNH patient is patient number 2 and half think patient number 1. Okay, so let me clarify again. Now, if this well has CD59 antibody incorporated in the gel. Now you add a red cell, you add a drop of red cell, patient's red cell. Now what happens here? The red cells are not able to cross the gel. That means an antigen antibody reaction has occurred here. So the patient's red cell, that means were bearing CD59, right? Similarly over here, CD55 was there in the gel, and when you added patient's red cell, there was an agglutination. That means the CD55 was present in the gel. So that in the patient's, on the patient's RBCs. So that means that this is a normal person who is expressing CD59 and 59 on the surface of the RBC. While if you see patient number 2, there is no antigen antibody reaction. That means the antigen was absent on the red cell surface. So this patient lacks CD55 and CD59, and that means this patient has PNH. Next, please. But the test of choice for diagnosing PNH has become flow cytometry, and I'll tell you why. Because flow cytometry not only identifies correctly the disease, it helps us in classifying the disease, whether it is a classical type of PNH or whether it is a subclinical PNH, which is associated with very small number of clone size. It can also evaluate the risk of progression. The larger the clone size, actually we give a quantifiable report. We actually tell the patient that this is the size of the abnormal clone in your body. So that clone size can be used to evaluate the risk of progression. And also because now there is a monoclonal antibody which is available against PNH, that is eculizumab. This is a monoclonal antibody which is directed at C3 convertase and prevents hemolysis in these patients. So we can also monitor the therapy to eculizumab by again and again looking at the clone size. So PNH flow is the method of choice for diagnosis as well as monitoring patients with PNH. The principle of flow cytometry in PNH is very simple. We simply gate certain populations and then we detect whether the GPI anchored proteins are present or not on those gated populations. Next, please. So for example, this is a dot plot where a certain population of interest has been gated. Okay. And these are 3 scenarios which can occur. In the first scenario, we make a frequency distribution plot or a histogram, and we see that all the cell population, the whole population is here expresses a high intensity of this CD59, which is expressed on the x-axis. So all the cells are expressing bright CD59. That means PNH negative. Okay. In this second scenario, we can see that there's a peak here. That is, most of the cells do express CD59, but there is another peak here in a region where there is no expression of CD59. So this is probably the PNH3 clone where there is no expression of CD59. Then there is this third scenario where we see that there are actually 3 peaks. So this is the normal expressing the type 1 clone, which are not GPI deficient. There is a type 3 clone, which is completely GPI deficient. And there is also a type 2 clone, which shows a partial deficiency. So as I told you, we can have 3 types of PNH clones, type 1, which are normal. And in case of red cells, they have a normal lifespan, that is of 120 days. The type 2 clone, which is partially deficient in GPI anchored proteins, almost have a half the life of the normal. And third are the complete GPI deficient protein PNH cells, where the life is only 10 to 15 days. Next, please. So now what is the sample that we use for PNH? The preferred sample is always peripheral blood. We do not prefer to do a PNH profiling on a bone marrow. Now the reason for this is that bone marrow has a lot of precursors. They are normoblast and granulocytic precursors. And these precursors do not express GPI anchored proteins properly. So that is why bone marrow is not the preferred sample. It should be done on peripheral blood. EDTA blood is well and good. You can also do it on heparin or ACD anticoagulated blood. Previously, it was said that for PNH, we could keep the sample for 7 days if we are looking at the RBCs, while the WBCs needed to be evaluated within 48 hours. But the latest recommendations, they recommend that the sample should be analyzed maximum within 48 hours. Now, there are 2 types of assays which are done for PNH. One are the routine assays, which are simply done for diagnostic purposes in routine labs. That is approximately, you need a cutoff of approximately 1%. So out of the total events you have gated, if 1% of the cells, they are showing GPI deficiency, you can diagnose a patient as PNH. But the other type of assays which are used in nowadays, they are commonly used. High sensitivity assays are those which take a much lower cutoff. That is a cutoff of approximately 0.01%. Obviously, to achieve this cutoff, you have to acquire much higher number of events. At least 2.5 to 3 lakh events have to be analyzed. And so this is the lower limit of detection, So even if you get a 0.01% population of the gated population lacking the PNH, lacking the GPI anchor, you can label the person as PNH positive. Now, which cell populations to analyze? So as I previously told you that the defect occurs at the level of the pluripotent stem cells, and all the cells are going to show you GPI deficiency. So it is recommended that you not only analyze the RBCs, but you also analyze the neutrophils as well as the monocytes. Now, lymphocytes are not taken in analysis. It is not that lymphocytes will not show you GPI deficiency, but why they are not used for analysis, I will provide the diagnostic algorithm, Dr. Pritesh, just wait for a minute. And why lymphocytes are not recommended is because lymphocytes, they have a very long lifespan and they have a variable expression of the GPI anchored proteins, right? So that is why these are the sample considerations. Next, please. So now talking about the antibody and fluorochrome selection, we have to take certain gating markers, which should be very specific, should be expressed on the population of interest on high numbers. All antibodies need to be titrated to their minimal dilution so that to optimize performance, to take care of the signal noise ratio. So dull antibodies should be tagged with brighter fluorochromes and vice versa. Next, please. So now into the RBC tube. So we'll discuss the RBC tube and we will discuss the WBC tube. So as far as gating marker is concerned, CD235A is the marker of choice if we talk about the RBC tube. Why CD235A? Because it is present in high copy numbers, not only in normal cells, but also in PNH red cells. And it will help us in identifying the true RBCs. Now I want your attention on this plot. This is a dot plot and this is a histogram. This is from the same sample. Okay. So if you look at this dot plot, on the x-axis is the CD59 and on the y-axis is CD235A. So obviously CD235A is a gating marker and CD59 is a marker for the expression of which we are going to check whether the cells lack CD59 or they do not. So if this is correlated with the histogram, this is the histogram from the same sample, you can see this population, this brighter population, the CD59 bright population can be seen here also. So obviously this is the normal population, the clone 1, the PNH1 clone, which does not lack the GPI anchor, right? And here is the third clone, which can be seen in this histogram. Now what we are going to talk about is this population. You can see these green cells and you can see these red cells. So if you just look at this histogram, which is just representing the number of events and the CD59 expression on those events, you will say or you will report the clone size as approximately 3% because in the histogram, the green and red population are clubbed together. Okay. Now, but looking at this dot plot, I see that on the y-axis, I have taken CD235A. Now here the green population is expressing CD235A of the same intensity as the red population and the blue population. But if you look at this population, this tail here, this is not expressing CD235A so well. So actually these are not true RBCs, these are degenerated or disintegrated RBCs, which we do not have to take into consideration. So actually the PNH2 clone size is much smaller here, but this will not be correctly interpreted if we are just looking at the histogram. So that is the advantage of using CD235A. Whenever you see a clone which is expressing CD59 to a lesser degree, you have to make sure that CD235 expression is as bright as normal cell, that is the PNH1 clone. So that is why CD235A has been recommended as a gating marker in the guidelines. Next, please. The only problem with CD235A is that it is prone to aggregation. So it is best to conjugate it to the FITC. So CD235A is always read in the FITC channel and the lowest concentration has to be used. You have to titrate and put up your experiment in such a way. And once you add CD235A, the sample should be acquired within 15 minutes. Next, please. So that was the gating marker CD235A and the GPI anchor. To look at the GPI deficiency, the anchor of choice is CD59. We know that both CD59 and 55 are missing as GPI anchors in PNH. But why CD59 is preferred over CD55 is because CD59 has a better capacity to delineate the 3 clones as compared to CD55. So again, this is the same sample. If you see the histogram for CD55, you will see that there is this normally expressing CD55 clone and there is the big clone which is lacking CD55. But when the same sample is analyzed using CD59, you see that this actually differentiates into 3 clones, the type 1 clone, the type 2 clone, and the type 3 clone. So type 2 and type 3 would not have been delineated if we were just looking at CD55. So CD59 is the gating GPI anchor of choice. So now how do you read the RBC tube after analysis? This is what I'm going to tell you here. So the first graph you're going to read is side scatter versus time. This takes care of the fluidics in the system. Then using a side scatter versus forward scatter, you gate your RBCs. And after that, you use CD235A versus forward scatter to finally take the true RBCs. You omit the small cap. These are actually the aggregates, which should not be taken for analysis. So this is your population of choice, which you have taken. And now you can look for expression of CD59 on this population. So this is a dot plot, which shows you can make your templates in time. This is the PNH1 clone, this is the PNH2 clone, and this is the PNH3 clone. Now, which plot is this? This is a density plot. Now, why density plots are important? Because sometimes there are minor populations which may not be seen in a dot plot. So to look at those clones, you also should be making your density plots. Here, the dot plot and density plot are showing you the same thing. And this is the histogram, which is also showing you that there are 3 clones. The clone size can either be assessed using a dot plot or the histogram. Next, please. Coming then to the WBC tube. So in RBC tube, just to remind you, we use just one GPI anchor and one gating marker. The gating marker was CD235A bound to FITC, and the GPI anchor was CD59, which was bound to phycoerythrin or PE. Now, when we come to WBC tube, they recommend the use of at least 2 gating markers and 2 GPI anchored markers to avoid any ambiguity. So CD45, which we normally use for gating, is highly recommended. So one of them will be CD45. The other marker used for gating neutrophils is CD15. Now, why CD15 specifically? Because when you just take neutrophils with the help of a side scatter CD45 plot, then you also include some eosinophils, basophils, or dendritic cells. Okay. By using CD15, you will be able to omit all those cells and you will be reading specifically the neutrophils. So initially, when the CD15 was not used as a gating marker, we used to call them granulocytes. But now specifically, we write the term neutrophil because we know that we are omitting the rest of the cells. Similarly, for gating monocytes, along with CD45, we use CD64 as the preferred gating marker. Next. So as I told you, you have to use at least 2 GPI anchor proteins or your population of interest. One of them is FLAIR. FLAIR is fluorescent aerolysin. The other one for neutrophils is CD24 and for monocytes is CD14. Now we know that we are not going to analyze our lymphocytes, but we are not going to exclude them from our gates. The reason is that lymphocytes, they serve as normal internal controls. So what is FLAIR? FLAIR is derived, it's an inactive aerolysin, which is derived from Aeromonas hydrophilia. And we normally conjugate it to Alexa 488 dye. So once it is conjugated to Alexa 488 dye, it can be read in the FITC channel. So our FITC channel is always occupied by FLAIR. Now this FLAIR directly binds to the GPI anchor and not the protein. So that is the advantage of using FLAIR. And it will bind to a wide variety of leukocytes where the GPI anchor is there. But it is not used for diagnosis of red cells and platelets. The reason is that these cells have to convert pro-aerolysin into aerolysin, and that cannot be done by red cells and platelets. That is why the red cells and platelets are not analyzed using FLAIR. It is only the leukocytes, the neutrophils and the monocytes, which are analyzed using FLAIR. It gives us very bright signals, and again, it has to be titrated to maximum dilution. Next, please. So if we talk of a 4-color panel, this is the recommended panel. For a neutrophil tube, you can put up 15 on PC5 and 45 on PC7. These will be the gating markers. And then FLAIR on FITC and CD24 and PE can serve as the GPI anchored markers. For a monocyte tube, CD64 and CD45 here on PC5 and PC7 are the gating markers, while FLAIR and CD14 will be the GPI anchored markers. Next, please. So coming to the WBC gate and WBC data analysis. So the first graph would always be a side scatter or a forward scatter versus time to check for the fluidics of the system. Then next would be a side scatter versus forward scatter where we exclude this debris. Then the again a side scatter versus CD45, draw a gate around the CD45 positive cells. And then on those CD45 cells, we can see the CD15 positive population. This is the population of neutrophils. Now, these neutrophils are simultaneously, a dot plot is made on the CD15 gated population to look for CD24 or flare deficiency. So you see this population here, it is expressing both flare and CD24. So that means it is not GPI deficient. Any GPI deficient population would fall in this gate. Now, suppose a population falls here. It is expressing flare, but not expressing CD24. So that population we will not take as GPI deficient. Unless the population does not express both these markers, we will not label it as GPI deficient. That is why at least 2 GPI markers have to be taken. Similarly, for monocytes, we gate them using CD64. And on that CD64 gated population, we look for the expression of CD14 as well as flare. So here is a population which is expressing both 14 and flare, right? Next. So similarly, you can have a 5-color panel. In a 5-color panel, obviously the FITC channel in the 5-color granulocyte and monocyte can both be studied in a same tube. Here, flare is there in the FITC channel. And in the PE channel, we add CD57. Now, the advantage of using CD157 is that it is a GPI anchored marker, which can be read on both neutrophils and monocytes. So you'll gate using the gating markers, and then you will read the population of interest for the expression of flare and CD157. Or else you can use a 6-color panel where instead of CD157, you can use CD24 and CD15. Next, please. Now coming to data analysis and reporting in PNH. So you have to report separately both the RBC as well as the WBC clones, and a clinical correlation is mandatory because you will get a smaller clone size in subclinical PNH, which needs to be serially monitored. Next, please. So talking of the RBC clone assessment of the RBC clone may not be very accurate because of hemolysis or transfusion. So when you give transfused RBCs, the transfused RBCs do not express CD59 so well. So you might interpret them falsely as a PNH type 2 clone. So you have to be very sure when you are analyzing your RBCs, the history of transfusion has to be taken. Now for RBC clone, the lower limit of detection is 1% for routine assays and 0.01% for high sensitivity assays. A practical guide is like that if you analyze 1 lakh events and you get a clone of 1%, then you can stop. But if you don't get a clone size and you're still suspecting PNH, then you go on further, acquire at least 2 or 3 lakh cells, and you look for 20 to 50 cells which are GPI deficient. And then you can give a report like that, rare cells with PNH phenotype below the level of quantification. Now for RBC, it is mandatory that both type 2 and type 3 clones have to be reported separately because it has a prognostic implication. Now, as I told you that what happens with transfused cells is that they express lower level of CD59 and sometimes they can be mistaken for type 2 clones. So here what we can do is that if there is a patient who has been transfused and you need to do a PNH assay, then a very practical technique is that you add CD71. Now CD71 is going to exclude the RBCs. It is only going to be positive on reticulocytes. So you add an extra gating marker that is 71. So you gate the cells using 71 and 235 and then look for CD59. Okay. So this is the CD71 positive reticulocyte here population, and it is expressing CD59. Okay. Next, please. So coming on to the WBC reporting, the clone size correlates. Remember, the WBC clone size will correlate better with the disease severity instead of the RBC clone size, and especially the monocyte clone. Again, you should acquire at least 50,000 neutrophils and at least 10,000 monocytes before you give a report. And the limit of detection here is again 0.01%. But in WBC clone, you don't need to report type 2 and type 3 cells separately. You can just report the type 2 and type 3 cells together. Next, please. So this is a sample report. You have to say which cells have you analyzed, then whether there's a partial deficiency, that is a type 2 clone, and whether there is a complete deficiency, the size of the clone has to be reported. The total size of the RBC clone, that is type 2 and type 3, needs to be reported. Similarly, for WBCs, that is monocytes, You have to tell which marker GPI anchors did you use for seeing the GPI PNH. And again, the clone size needs to be reported. So this is the sample report here. Next, please. Next, please. So the next disease we come on for which we can use flow cytometry is hereditary spherocytosis. So in hereditary spherocytosis, again looking at the lipid bilayer, this is the lipid bilayer here. And the lipid bilayer is supported in shape and integrity with the help of a cytoskeleton, which is below the lipid bilayer, made up of the alpha and beta spectrin. And the lipid bilayer is anchored to the cytoskeleton with the help of band 3, 4.2 and enchirin proteins. Next. So what happens in hereditary spherocytosis? There is a deficiency in one or more of the cytoskeletal proteins, either spectrin, most commonly beta spectrin, but it can also be alpha and beta spectrin or anchirin or any other protein. So as a result, what happens? The membrane is very unstable. And in circulation, it is lost in the form of microvesicles. To accommodate for that lost membrane, the RBC assumes a spherocytic shape because the sphere has a lesser surface area for the same volume. So the RBCs become spherocytic, and when they pass through the spleen, they undergo splenic conditioning. They further become microspherocytic. So these microspherocytes are the hallmark of hereditary spherocytosis, which can be very well seen on a peripheral smear. Next, please. So there are a huge number of diagnostic modalities which have been developed for hereditary spherocytosis. Obviously, the role of CBC, as Dr. Vandana told you, the mean corpuscular hemoglobin volume, the sphere cell volume, and the peripheral smear showing you spherocyte. These are the common ways in which you start suspecting HS. Bagi osmotic fragility test, we all know that is the test which has been conventionally used for workup of hereditary spherocytosis. Apart from that, we also have the acidified glycerol lysis time, the cryohemolysis test, and the ectacytometry. And further these tests, molecular test and SDS phage electrophoresis is usually done only in research labs. So there are a huge lot of modalities which have been used for the diagnosis of hereditary spherocytosis. Next, please. So then if we have so many tests, then what are the recommendations? So supposedly there's a patient who shows typical clinical features of spherocytosis. He has hemolytic anemia, he has splenomegaly, he has a family history or somebody from the family also shows spherocytes, and there are typical CBC findings also. Then you do not need to do any further test. You can simply label that patient as hereditary spherocytosis. However, if the case is not so straightforward, then you need to go for a screening test, which has a high predictive value. Now for that, only 2 screening tests have been recommended. The recommendations only suggest use of 2 screening tests, that is the EMA dye binding test or the cryohemolysis test. Please note that routine OFT is not recommended for use as a routine screening test. That the results of routine OFT are only supportive. Now suppose your screening test is also equivocal, then you need to do a gel electrophoresis, which can be an SDS phage gel electrophoresis. The use of molecular test is not recommended for diagnosis of hereditary spherocytosis. So now talking about the EMA dye binding test or the eosin 5 malamide dye binding test. So what this EMA dye does is, or how it helps us in seeing hereditary spherocytosis is that, next please, the dye actually, next please, the dye binds to the band 3 protein and also to the RH complex here. Next, please. It binds to the RH complex. So it can bind to the band 3 and RH complex, and that is why it helps us in seeing whether the cytoskeleton is intact or not. So what we do in this test is that the RBC are treated with the EMA dye, and after treating with the EMA dye, we just measure the mean fluorescence intensity in the cytometer. So for each test, we run 5 controls to see what is the MFI, which is expressed by controls, and the reduction in fluorescence intensity is used for diagnosis. Next, please. So this is a simple analysis here. The RBCs have been gated, and these are again the aggregates which have been omitted, right? You have to omit these aggregates. You just gate the RBCs, and then a simple histogram is read to see for EMA expression. And here you can see that in the case, the EMA expression is here, but in the control, the EMA expression is higher. So there is a reduction in the expression of MFI for the case. Next, please. So you can also quantify the test. The text can be objectified. It can be quantified by calculating the percentage decrease in the fluorescence intensity, which is calculated by the simple formula, the decrease in the intensity divided by the, just give me a minute. Sorry, just give me a minute. Hello. मयंक ने बहुत important talk में हुआ, so please 15 मिनट बाद आप. So we can look at the percentage decrease in the fluorescence intensity, and that will help us objectify the results. Next, please. So the interpretation of the test is that if there is up to 15% decrease in the fluorescence intensity of the case as compared to the control, then it is not a case of hereditary spherocytosis. 15 to 20% is possible. Then you have to supplement it with another test, for example, a cryohemolysis or an ECTA cytometry or an SDS page analysis. And if the percentage increase in fluorescence intensity is more than equal to 20%, then it is probably HS. You just have to correlate with the clinical history. Now, there's a word of caution here that every lab has to establish its own cutoff, and sometimes it may vary from 8% to as high as 21%. Next, please. So this EMA dye binding test has been found to be sensitive and highly specific with a very high predictive value. It is reproducible, and it is definitely superior to the osmotic fragility test for identifying hereditary spherocytosis. Next. The main advantage of the test is that it does not rely on the shape of the RBC. So we are not using the spherocytic shape as we use in osmotic fragility, right? So it can differentiate hereditary spherocytosis from all other causes which are associated with spherocytosis. And it's a very rapid test. You need a very small sample volume. Just 500 microliters should be enough. So that can be very easily carried out on infants and neonates. The test can also be abnormal in CDA type 2, Southeast Asian ovelocytosis or cryohydrocytosis, but these diseases can be differentiated from hereditary spherocytosis simply looking at the smear findings. Next, please. So you will be surprised that the osmotic fragility test can also be done using a flow cytometry, and the advantage is that now it becomes better and more objective. Now, this is a graph which we all have seen, that utilizing the property of spherocytes, that they become more osmotically fragile and they break up as the concentration of hypotonic saline increases. So this is a normal range, and in the x-axis represents the NaCl concentration and the y-axis represents the percent hemolysis. And in a patient of hereditary spherocytosis, the graph shifts to right. So for any given concentration of NaCl, the amount of hemolysis is increased. While in sickle cell anemia and thalassemia, the graph shifts to left because of the dehydration of the RBCs. Next. So here what we do is that the red cells are suspended in isotonic saline, and initially the flow cytometer is run for around 30 seconds and the number of events is noted. Then the analysis is stopped, distilled water is added to the sample, and the run is again started, and more time gates are acquired for up to 300 seconds. So then we see what are the number of events left at the end of analysis. So the number of events left at the analysis are the residual cells. So then we calculate the percent residual red cells, and this is the ratio between the number of events at the end of analysis to the beginning of analysis. So more are the number of residual red cells, less osmotically fragile these cells are, and less is the likelihood of hereditary spherocytosis. Next, please. So I'll show you how we do it. These are our RBCs, and here we have the first time gate. These are the number of events being taken. The analysis has been stopped and distilled water has been added, and more time gates have been acquired. Now this is the end of 300 seconds. This is another sample where we have done the same thing here. Now look at the difference between here and here. The number of events here and here are almost the same. So the percent residual red cells is approximately 89% here. However, in this patient, the percent of residual red cells at the end of analysis is just 19%. Okay, next, please. So again, you can calculate the percent residual red cells using the simple formula. Next. So again, each lab has to establish its own cutoff, that how much percentage, at what percentage of residual, below what percentage of residual red cells you will report a patient as hereditary spherocytosis. So at least 10 to 20 controls have to be run. You have to see what lower cutoff value of residual red cells you need to decide. Next. So if you compare the EMA dye binding test and the flow cytometric osmotic fragility test, each one has its own advantage. The sample is stable for approximately 7 days if we talk of the EMA dye binding test, while flow cytometry has to be done on the same day, right? They are both sensitive and specific. The specificity of FCOFT is slightly higher. And if you look at flow cytometry, osmotic fragility, we are just using distilled water and nothing else. So it's a very inexpensive investigation. If you already have a flow cytometer in your lab, then there is no harm in doing it. You need nothing else. And the percentage of the residual red cells also correlates with the severity. So that is an added advantage of doing a flow cytometry OFT. Next, please. So the next evaluation or the next investigation which we can do with a flow cytometer is a evaluation of DAT negative, direct antiglobulin test negative autoimmune hemolytic anemia. So what is autoimmune hemolytic anemia? We all know that there are autoantibodies which are bound to the surface of the red cells. We add the Coombs reagent and an agglutination indicates the Coombs reagent is nothing but anti-IgG. Okay. And when we, because these are incomplete antibodies, they are not capable of agglutinating RBCs on themselves. When we add the Coombs reagent, the RBCs get agglutinated. Agglutination is a positive reaction. That means the antibodies were present on the red cell surface. But the problem here is that 5 to 10%, yeah, next please. So 5 to 10% of patients with autoimmune hemolytic anemias may be negative for that by the conventional tube technique. Okay. Now the main reason for this is that the number of antibodies which are bound to the red cells are lower than the limit of detection. For a conventional tube technique, you need that at least 500 antibodies are bound to the surface of one RBC. Okay. Sometimes the affinity of the IgG is low. That is before in vitro, it detaches before you can detect it. And sometimes it is not the IgG, but the IgA or IgM, which is bound to the red cell. And your conventional Coombs reagent only has anti-IgG and anti-C3, and that is why you are not able to get a positive DAT. So there are alternative techniques which have been developed to improve this. That is the microcolumn technique, the polybrine immunoradiometric assays, and so on. And till date, however, there is no diagnostic algorithm for Coombs negative autoimmune hemolytic anemias. Next, please. So the principle again is very simple. Over here by a flow cytometry, what we do is we take the RBCs, assuming the RBCs are 1% washed red cells are taken, assuming that the antibodies are bound to its surface, right? And then what we do is we use an anti-human, Goat's anti-human immunoglobulin, which is conjugated with FITC. And then the sample is analyzed. We do run positive and negative controls. The positive controls are O positive cells, which have been coated with this anti-IgG, and negative controls are simply healthy O positive cells. Next, please. So here you can see that we have gated the population of interest using the side scatter and the forward scatter. We have excluded the debris here. And on this x-axis is the IgG conjugated to FITC. So this population is expressing IgG. So that means the Coombs test is positive with the help of a flow cytometry. Next, please. Next. So how do you decide? You can also again quantify it. You take the mean fluorescence intensity of 10 negative controls. If the fluorescence intensity expressed by the case is more than 2 standard deviation above the mean MFI, which was calculated using 10 negative control, then that case is called as positive. So what I'm trying to stress again and again is that when you use the same technique by flow cytometry, be it the osmotic fragility test or the Coombs test or the EMA dye, we are actually able to quantify the results, and that makes the reporting more standardized. Next, please. So you can also quantify the percent fluorescence. So the advantage here is that the test is inexpensive, highly increased sensitivity, which helps us in early detection and diagnosis, and it is quantifiable, which helps in follow-up. So the last thing we can do using a flow cytometry, or a last thing I have taken up in the slide, is the estimation of feto-maternal hemorrhage. So feto-maternal hemorrhage is estimated in many situations, especially for obstetric management of RH dealuminization cases. So for feto-maternal hemorrhages, traditionally we were using the Kleor-Betke test, in which we used to stain the hemoglobin F cells. Now this Kleor-Betke test is again a very subjective test. It has a poor reproducibility, and generally we overestimate the number of F cells. Now, flow-based techniques are more accurate, and they are now called as gold standard for the estimation of feto-maternal hemorrhage. So here what we utilize is that the fetal red cells will have HbF. So we take an antibody to HbF. We take another antibody which is conjugated to which is anti-carbonic anhydrase. Now, anti-carbonic anhydrase will only be expressed by the maternal cells, the normal mature RBCs of the mother. And the HbF will be positive in the fetus. So those cells which express HbF but do not express carbonic anhydrase are the fetal cells which are present in the maternal circulation. Those cells which express carbonic anhydrase but no HbF are the normal maternal RBCs, while those cells which express both F and carbonic anhydrase are going to be the maternal F cells, which are obviously going to be less than 1% as we see in any adult. Next, please. So here is a simple assay. On the x-axis, on the y-axis, x-axis, we take carbonic anhydrase is taken, and on the x-axis, fetal hemoglobin is taken, right? So here you can see that most of these cells are the maternal red cells, which are expressing carbonic anhydrase, but no HbF. But there is a population of fetal red cells expressing HbF, but no carbonic anhydrase. So again, the percentage of fetal cells can be converted into the number of fetal cells in ml using this Mollison's formula. So that is how flow cytometry can help us in evaluating many hemolytic diseases. The main advantage here is that the test becomes very objectified, quantifiable, helps us in prognosis, and helps us in clearly deciding that whether the patient has a disease or not. So what are the future directions? Yet not many labs have standardized these tests. They are still done as research purposes. So we need to standardize, and we need larger databases, because I told you that every lab has to establish their own cutoff. So we need better cutoffs and better databases to which we can compare our patients. Next, please. So then again, flow cytometry has also been the osmotic fragility test, flow-based osmotic fragility test has also been used for there is a publication here in 2016. They used FC OFT for the evaluation of hemoglobinopathy, basically alpha thalassemia. We all know that alpha thalassemias are the ones which are difficult to diagnose because they cannot be diagnosed using an HPLC. So the authors found that they were able to catch up around 80% of the patients using flow cytometry based OFT. Then there is another publication based where they have utilized flow cytometric assay for evaluation of G6PD and to differentiate these subjects from anemic subjects. So these are some of the publications which have just come up, and that is all for today. Thank you for listening.